how the robot works. That's why they are interacting.
Clinical result along with the wow factor to the patient.
Yeah, but one problem, sir, if you show to the patient, next time he will go out, he will do the surgery.
Thank you, sir.
सर्जन से काम नहीं आता.
Thank you, sir, for sharing your experience with us. We have a slight change in schedule. Dr. Bowlers is ready to talk, so we'll be moving on to that now. Unfortunately, Dr. Bowlers could not make it personally, hence we are connecting with him live over a Zoom call. I request Dr. Jagan Mohan Reddy also to kindly take the session along with the other panelists. I invite Dr. Peter Bowlers to speak on alignment philosophies in knee arthroplasty. But before that, I would like to give a brief introduction. It is my pleasure to introduce Dr. Peter Bowlers, a renowned specialist in knee and shoulder arthroplasty and sports medicine from St. Trudeau Hospital in Belgium, where he has been serving since 2012. Dr. Bowlers is a pioneer in robotic assisted arthroplasty surgery. He has performed his first Navio robotic case in March 2018, and ever since he has completed more than 1,350 Navio and Cori total knee arthroplasty and unicompartmental knee arthroplasty procedures. He has also contributed extensively to clinical research with 10 published papers on robotic knee surgery between 2020 and 2025. He is also serving as a consultant with Smith & Nephew, particularly advancing innovation in orthopedic care. Please join me in welcoming Dr. Peter Bowlers.
Thank you for your nice introduction. I hope everybody knows me very well. So my topic will go about alignment philosophies and knee robotics. This is already the introduction that they give. So what do we want as a surgeon? We want to have 100% happy patients. But we also know that not every patient is a happy patient after knee surgery. We know that the expectations of the patients after the knee are greater than we finally can perform in the knee. Factors that can be from influence of a successful total knee arthroplasty are patient selection. These, of course, a very good indication of the knee. Component design, surgical experience, optimal pain protocol and rehab. That's for me very important. For example, we use nowadays adductor blocks, and that gives an additional value of the first 24 hours of the rehab. And accuracy of implementation and soft tissue balancing. Those two topics are very important for the surgeon during surgery. We also know that 50% of the revisions are done within the 2 years after the primary surgery. Reasons for early failure are fixation failure of cement technique, instability and malalignment, and those two we have to attack during surgery. What we don't want to have after surgery is this preoperative varus case of 4 degrees, and we will end up with a valgus deformity of 8. Of course, this is a case of early failure of knee arthroplasty. This was a case of alignment, but what is a good alignment problem? You have mechanical alignment, kinetic alignment, constitutional alignment, restricted, you have a lot of them. But we were told that a good alignment is the frontal plane should be at 3 degrees from a neutral mechanical axis, straight legs. A deviation of more than 3 degrees, that's called an outlier, and is associated with an increased failure rate and a decrease in survival, not just in the frontal plane, but also in the horizontal plane for patellofemoral problems. And what is a good balanced knee? We take an extension as about a gap opening of 1 to 2 at the medial lateral side and extension, and in flexion, a little bit more in deep lateral flexion because of the normal pivot of the normal kinematics of the knee. But how to achieve the forgotten knee? Of course, we need accurate bone cuts and we need well-balanced ligaments. But to achieve this goal, we need tools for accuracy, precision, because we can't do it every time again as a human being. In the timeline of the total knee arthroplasty, we start with conventional instrumentation, afterwards navigation and PSI technology, and nowadays it's all about robotics. But all of those have the same goal. We have to reduce the potential outliers, we have to improve accuracy, so we can increase patient satisfaction, and of course it has to be easy to use and it has cost effective. So what are the problems with the conventional technique, PSI and navigation? They have moderate to good bone cuts, but there was no difference in crumbs in literature. Why? There was no difference. Maybe because we have to pay more attention to the kinematics. We have to pay more attention and respect to the soft tissue. And this is for me the introduction of the alignment techniques. As we told, we know the mechanical alignment is a stable knee in a neutral aligned lower limb. It does not restore the constitutional alignment of the patient and is biomechanically friendly prosthesis knee. It is introduced by the group of Insol a long time ago, and there was a consensus that the best alignment corresponds to the mechanical axis, even when this position does not necessarily correspond to the original anatomy of the individual patient. We know that there is a systematic approach for everybody. Everybody has the same straight legs. That's what we thought. We know there is a good long-term implant survivorship, but we also know that there is disappointing functional outcome in 1 of 5 patients. 20% is not happy, despite many improvements in implant design and also in precision of surgery, despite the accuracy of PSI navigation. There is more and more growing interest in more anatomic surgical techniques. This is a paper published by Hirschman already in 2019, before the corona, and they show that if we want to improve kinematics and functional outcomes, we have to be more careful with the individual morphotype of the patient. They conclude that not everybody has the same anatomy. And this is already a paper from almost 20 years ago by Professor Belmans. He was my teacher when I was a resident in Belgium. And he developed the concept of the constitutional alignment. That means that not every patient, when he has a healthy young knee, he has a straight leg. You see in Belgium, the overall alignment of young healthy people is about 2 degrees of errors. So we adjust a little bit the mechanical alignment philosophy. We made an adaptation. He does an undercorrection of the constitutional frontal deformity to a maximum of 3 degrees. He made his adaptation of the femur and not of the tibia. This is by the concept of the constitutional alignment by Professor Belmans and Professor Bickler. But doing this with the conventional instrumentation is not accurate. It's a little bit more eyeballing. On the other side, you have the kinematic alignment. It's a true knee resurfacing technique, and it is patient-specific and ligament-sparing. It restores the native pre-arthritic limb and joint alignment of the patient. You can do it by measuring resection, so you take out the expected thickness of the bone and the cartilage. We know from the kinematic alignment technique, from early and interim results, that they have good functional outcome, even better than the mechanical one, similar revision rates, but there are a lot of limitations and pitfalls. Kinematic alignment is not suitable for every patient. So, for example, with a severe constitutional variance of more than 5 degrees of the proximal tibia joint line, but also the tibia plateau, or a valgus deformity with MCL stretch of patellofemoral problems, those are not good candidates for TKA with kinematic alignment. And I'm sure that in your countries, most of the patients come with this kind of problems. So they develop restricted kinematic alignment technique that's more restricted than the kinematic alignment. So they have limitations. So for example, they just do it when there is less than 3 degrees of constitutional frontal limb deformity and there is less than 5 joint line obliquity. They try to stay more in the safe zone alignment. So here is a quick overview in my head of different kind of alignment philosophies, because you have a lot of them. The first one, of course, the native knee of the constitutional alignment is patient. Then, over to the right side, we have a systematic approach. It's called the mechanical alignment, straight legs. The other side, you have the patient-specific alignment, like we do for a uni, where we will do a real resurfacing, or the kinematic alignment, like I just explained. And then in between, you have a hybrid technique, or the hybrid alignment. There's something in between kinematic and mechanical alignment that has a lot of names. You can call it restricted kinematic, reverse kinematic, adjusted mechanical axis. So you have a lot of them. And we will see we have a new name to give this hybrid alignment technique. So how to achieve this desired alignment technique? Of course, you can try to use conventional instrumentation, measurement section, navigation, PSI, navigation, and robotics. So by using robotics, this is a paper published by the group of Haddad in 2020. They make the first connection with hybrid philosophy of the functional alignment. That's something in between mechanical alignment, or it's just body, kinematic alignment with just respect to soft tissue. But functional alignment is a hybrid technique that allows mechanically sound but also soft tissue friendly alignment targets. It's called functional alignment. In 2027, we had the introduction of a robotic system in our hospital. We first started with the Navia, and nowadays it's all about Cori. As you probably know, it's a handheld robotic system with a high degree of accuracy. It's an image-free platform, with for sure in the future you can use it as an image-based platform as well. Patients or surgeons would like to use this kind of technique. You can use it for several indications, uni stones of patellofemoral, also for revisions I use it nowadays. And it has a very patient-specific planning for the surgeon. Why you should use it, or I should use it, is because I believe in additional value. In Belgium, it's not a competition anymore, it's not a high. We believe in additional value. And additional value, there are two very important things. It's a tool to assist. It's not a robotic system to do the surgery for us, but it's a tool to assist the surgeon and gives me a higher degree of accuracy. And it gives me as a surgeon the freedom in alignment philosophy. Both are for me fundamental aspects in robotics. In Belgium, already 41% of every surgeon using a label technology. Here you can see the difference between the Cori and the vision and cutting blocks. That in Belgium is very well incorporated in the healthcare system. So what is proven already is that the robotic assisted system allows the desired alignment and positioning as planned. That means that if you plan something, you achieve everything in almost 91% with an error as less than 1 degree of 1 millimeter. This is proven. There are many literature that is available that accuracy is fundamental and is proven. So for me, robotics is a feedback tool that gives me feedback about bony alignment and soft tissue, but I can't say it was a perfect position for every patient. That is still something that we have to examine. So in my daily practice, I made a shift from a loose mechanical axis to a more personalized hybrid alignment. Nowadays it's called functional alignment, and I try to stay as much as possible at the soft tissue level. To achieve this goal, I can use 6 degrees of freedom, and with 6 degrees of freedom, I mean you can give flexion and extension to the femur of the tibia, you can give endo-rotation or exo-rotation on the tibia femur, and you can also give varus of valgus. So you can play with prosthesis to get the perfect fit in a well-balanced knee. In my hospital, we have a commitment with the hospital and the University of Maastricht to do research. And we published, as you have heard in the introduction, already 10 scientific papers about robotics in knee arthroplasty. The first one that we did was almost 5 years ago. It was 77 cases with robotics, with a match control group without robotics, and we just checked the alignment. And there we see that we had just 5 outliers in the robotic group, 6%. Or if you compare this with the non-robotic group, it was 18%. So there was a major difference in alignment accuracy between robotics and non-robotics in the early results. We did a retrospective study 2 years later with those patients, and we give them questionnaires to check their happiness. And here we see that there was a significant difference in the forgotten joint score and Oxford score while using the robotic system. We did another study, a CT-based study, that means that we did with 26 patients with robotics and 26 patients without robotics. The CT scan pre and post-op, and we check accuracy because you know that the X-ray is not the gold standard to measure accuracy, but it's CT. So those are the results of the study that we published in the CASCA a couple of years ago, and you see a difference between the robotic group, it's RAPCA, and the non-robotic group, the conventional TKA, and you see that the amount of outliers downstairs is 24.4 degrees percent in the non-robotic group, in comparison just with 5.8% in the robotic group. And the most important maybe to take home is the achieved various value disposition between the difference between the robotic and the non-robotic. You see in the non-robotic group we have a lot of outliers, and in the robotic group we have 0% of outliers. The reason for that is probably because for the achieved various value disposition, I use the burr from the Corey system. And by using the burr, no error at all. We see a slight kind of error when you use a saw blade. For example, for the rotation of the paravalis or the tibia, the slope. So by using the saw blade, be sure that you are sure that you correct the alignment in the position afterwards. Using the saw blade, we can create error for sure when you have hard on. By using the burr function with robotics, with the netting tool, no outliers. So we also published a paper to explain how to achieve the functional alignment in total neutral velocity. We took the results from the robotic system. You will have the RE inside. You can use it for give information to the patient or for on files, but you can also extract data to, for example, publish scientific work. A friend of me is a surgeon in Dubai, and we put our results together in 2021. And then we make a distinction between severe varus of slight varus, 7 degrees of varus pre-op, of less than 7 degrees varus, and we did the same for the pelvis. And then we see that we planned for a varus of over 7, an overall alignment at the end of the surgery of 2.8, and we achieved 3.6. So we don't plan them straight, we give them a slight overall rest varus. For less than 7 degrees of varus, we plan them for 1.49. We achieved 1.8. So you see, we don't plan for 0. We leave some additional varus values like the velocity, so we like the idea of the constitutional alignment. How do we do this functional alignment technique? So first of all, the principle of shape matching is very, very important. Shape matching, that means that you put the prosthesis depending on the body landmarks. So I start first ML with the size, then I try to restore the proper groove. Afterwards, when you have a varus knee, of course, the lateral side is the more healthy side, and you try to reconstruct the healthy side for the distal and the posterior femur. So I use a journey 2, that means thickness of the prosthesis of 7.5. So I try to mimic the 7.5 by shape matching the femur, distal, and posteriorly at the lateral side. So in that way, I can reconstruct the joint line, and that's very, very important. And afterwards, we do the adaptation to the tibia just by the height by shape matching, and then we go for the next step. That's balancing of the gap assessment. I use a Z retractor and do surgery, you get the information. For the lateral compartment is the purple, and the orange is the medial compartment. So in this case, you see in this varus, slight varus of 4 degrees, he is already put at the lateral side because you put him on his anatomic position. And a slight tightness at the medial side. So if you go to the right screen, you can play with the system. You see there on the lateral side, you get almost good. At the medial side, is a little bit too tight. And what we do then, we give slight additional varus in the femur and slight additional varus in the tibia. You see just 1 degree. And overall, we have an accepted balance in the good position of the bony ligaments. So we tried this philosophy already for 2029. It is a very easy concept to integrate in your daily practice. It's called the constitutional alignment philosophy, or another name is functional alignment. So we published also clinical data prospective study in the knee this year, 1-year results of a randomized control trial, and we examined 90 patients with robotics and 90% with 90 patients with robotics. You see, and that's maybe very important also in your countries, the amount of releases that have to be done with the robotic system is very, very low. You see here 6% in comparison with 51%. I come back to this at the end of my presentation, that you see in my hands in Belgium, we don't like robotic, we don't like ligament releasing because we try to stay in soft tissue, and you see here the big difference. And that represents itself also in the outcome. So Oxford knee score, Leas, ET5T, VAS, floating joint score, you see the right side, we saw a significant difference in all of them at the 1-year results. Everybody knows probably also the CPAC application, so we start this kind of philosophy.